We've spoken to lots of representatives from MD Anderson Cancer Center so far today. There's lots of research coming up at this year's conference. If we could have maybe a few of your highlights.
I would probably focus on acute leukemias, particularly acute myeloid leukemia. I think the biggest area of excitement is the fact that we are understanding the biology of leukaemogenesis better, and this is reflected in many studies looking at molecular pathogenic pathways and are better defining these molecular aberrations in leukemia, and this is leading to newer agents for subsets of leukemia such as FLT3 mutated or IDH mutated AML. But another area of excitement is the use of monoclonal antibody-based therapies with a number of antibody-drug conjugates that are now being evaluated in clinical trials, including also bispecific antibodies which are there to stimulate the immune system. So for example, there are presentations on a couple of antibody-drug conjugates. One is SL401 and another one, Seattle Genetics Vadastuximab Telerin, and also there are presentations in acute lymphoblastic leukemia using some of the newer strategies such as antibody-based therapies as well as CAR T-cell therapies.
We could maybe take a moment to think about, based on everything that's coming out of this year and the ongoing trials, where you'd like to see research heading in the next few years, some results you might see maturing by this time next year or the next few conferences.
So we already have had a couple of positive randomized trials in AML, which is exciting because over the last couple of decades we haven't been able to get any new drugs approved in AML, and well, we did one drug, gemtuzumab ozogamicin, which was later withdrawn from the market, although I still think it's a useful drug and it's hopefully going to make its way back. We, as I mentioned, we have similar antibody-drug conjugates that probably are going to be more active and less toxic, such as vadastuximab, and also other antibody-based strategies that I mentioned, such as bispecific antibodies. There's a couple of them, or several of them, that are under investigation in AML, and as I mentioned, target-specific molecular inhibitors, such as FLT3 inhibitors, IDH2 and IDH1 inhibitors, and interestingly, BCL2 inhibitors. Venetoclax has been approved for subsets of patients with chronic lymphocytic leukemia, but is of a lot of interest in other cancers and leukemias, and it's being investigated in acute myeloid leukemia, and I'm sure it will be investigated in other leukemias as well. And early results suggest that addition of venetoclax to either low-dose RSE or hypomethylating agents can be very beneficial and is relatively non-toxic, especially in the older population, which we have been trying to avoid cytotoxic chemotherapy-induced toxicity over the last decade.
Well, I think that's everything. Is there anything you'd like to add or anything else that comes to mind?
The only other thing I would think as of note is there is a lot more interest in minimal residual disease monitoring, and I think that in itself is an important area because essentially what it means is better definition of response with better assays. Historically, we've used morphological complete remission, which is highly dependent on pathologists and relatively insensitive. With these new assays such as multi-parameter flow cytometry and even more sensitive assays such as PCR and next generation sequencing, we can define which patients are in actual complete remission, when we call them complete remission, hopefully with essentially no disease burden left behind in the subset that become negative. And clearly this is going to be important both in terms of post-remission decision making. Clearly you don't want to subject a patient who is in an excellent remission to an allogeneic transplant, but also in terms of monitoring and following up patients.